So welcome everyone. I'd like to go ahead and open the Central Oregon Health Council meeting. Looks like Rick Trelevin's taking a call from the president, so we'll give him a moment. Lovely for everyone to join us today and appreciative of your time. We are hoping to meet in person after the first of the year, but I think today, given the weather, it probably makes great sense for us to meet virtually anyway. So the first thing on our agenda is our welcome and our going around to meet everyone. And so how about let's start on my screen and maybe we can hand it off. So I have Gwen Jones. Do you mind kicking us off with introductions, please?
Absolutely. I'm Gwen Jones, pronouns she, her, hers, and project manager. Nice to see you all today.
And let's toss it to Michaela.
Hello, everyone. Michaela Arsenault, project manager at the Health Council, and my pronouns are she, her, hers.
Great. And how about Miguel?
Hello, everybody. Miguel Ángel Herrada, project manager, pronouns he, him.
Wonderful. Camille.
I'm Camille Smith, the executive assistant with the Central Oregon Health Council.
Wonderful. Carmen.
Carmen Madrid, Executive Director, Central Oregon Health Council.
Also known as Demi Moore today with the voice. Love it.
Yes.
Whitney.
Hi, everyone. My name is Whitney Schumacher. I use she, her pronouns, and I am the newest project manager with the Central Oregon Health Council. I'm on my second week.
Woo!
Yeah.
Welcome. Great to have you with us today.
Thank you.
Mike Shercliffe.
Happy holidays, everybody. Representing Redmond Dental Group, ex-CEO of Advantage Dental, and nice to see you all.
Great to see you as well. Jeff Davis.
Hello, I'm Jeff Davis. I'm with Pacific Source, the CCO, Medicaid Medical Director.
Wonderful. Nice to see you. Rick, wearing many hats today. We can see you're very busy.
Hey, I'm Rick Trelevin, CEO, Best Care Treatment Services, and the behavioral health rep on the committee.
Groovy. Nice to see you. Let's see. Let's go to the Justins. So I'm going to go, Justin, I'm going to get your last name wrong. Sorry. You say it and then I'll repeat it. Sorry.
Samudio.
Samudio. Thank you. Samudio.
Sure. Justin Samudio. I am the Director of Financial Planning and Analysis at Pacific Source.
Excellent. Thank you. And our board member, Justin.
I'm Justin Civil. I'm the Chief Operating Officer for Summit Health.
Excellent. Wonderful to see you. Iman.
Hi, good afternoon. I'm Iman Simmons, and I serve as St. Charles Chief Operating Officer.
Excellent. Nice to see you. Gary Allen.
Hello, I am Gary Allen, Vice President of Clinical Services for Advantage Dental.
Wonderful. Megan.
Hi, Megan Hayes with Mosaic Medical and Safety Net representative.
Great to see you. Linda, partner in crime. Oop, and we're on mute.
Linda Johnson, community representative on the Health Council.
Excellent. Kelly.
Hi, everyone. Kelly Adams, she, her, hers, admin assistant for the Health Council.
Great. Brad.
Hi, everyone. Brad Porterfield, consumer representative and chair of the Community Advisory Council.
Excellent. Trisha.
Hello, everyone. Trisha Wilder. I use she, her pronouns. I am the CCO director for Central Oregon for Pacific Source.
Wonderful. Patty.
Patty Adair, Deschutes County Commissioner, just driving in from Sun River where it's snowing too.
Yes, 'tis the season. Yeah. Dustin. Oh, sorry. Dustin.
Hi, everyone. Dustin Zimmerman, he, him, his, your innovator agent with the Oregon Health Authority.
Love it. Paul Andrews.
Hi, everyone. Paul Andrews, Superintendent, High Desert ESD. We'll keep my video off because I'm challenged by COVID right now, but good to see everyone.
Well, we're sending good vibes your way. Elizabeth.
Hi, I'm Elizabeth Schmidt. I'm the vice chair of the CAC. And that's it. Thank you.
Wonderful. Well, that's an important role. Glad that you could join us today, Elizabeth.
Thank
Leslie.
you.
Oh, yes, Leslie.
Hi, Leslie Meyer, Senior Director of Medicaid Governance at Pacific Source.
Groovy, nice to have you. And Zaria, am I getting that right? Oh, connecting. Uh-oh.
There it is. Hi, everyone. My name is Zaira. I'm here as a guest with Pacific Source. I'm the new Marion Polk County CCO Director.
Wonderful. Great to have you with us today.
Nice to meet you all.
Yes, if we could be a resource to you, just count us in. So great to see you today. And it looks like Kat Mastrangelo is joining us. Did I miss anyone? The boxes were sort of moving around a tad. Kat, do you want to say hello?
Hi, this is Kat Mastrangelo, and I'm the Executive Director at Volunteers in Medicine. Very happy to see you all.
Wonderful. Okay. So with that, if I didn't miss anyone, we will go right into the agenda. And
Tammy?
hold on,
Sorry,
Oh.
this is Matt Swafford.
Oh,
the
Matt,
Chief Financial
sorry.
Officer. That's okay. Chief
Hi,
Financial
Matt.
Officer at St. Charles Health System.
Okay, thank you, Matt. Sorry about that.
No
As all
worries.
the boxes were reshuffling, I didn't catch that. So wonderful to see you. Anyone else? Okay. So next we have the consent agenda, and we did have a request to move the budget from the consent to the main agenda. So I will go ahead and do that. And so let's do it in 2 steps. We will go ahead and remove that from the agenda, and then I would welcome a motion to accept the consent agenda with that revision.
This is Gary Allen. I will move we accept the consent agenda with the revision of the financial report.
Excellent.
I will second. This is Linda.
Thank you, Linda. Any further discussion? And instead of talking over each other, if anyone is opposed, please let us know. Okay, motion carries. So Carmen, I'll turn it to you and we can go through the financial report. Thank you.
Great. Okay, so the next piece on the agenda is your board officer election. As you know,
So were we wanting to give any background in terms of the budget that we would be, or the financials that we'd be bringing back?
oh, do you want to do that now? It's down below on the budget, on the agenda.
Okay, so,
After determination.
okay, very good. That works for me too. Just making sure that that's what you wanted. Okay.
Okay. All right, so back to board officer elections. As you know, we did an online voting through email to elect your board officers for 2023. I received a majority of votes from the board, and they were unanimous in electing our slate. This is our slate, and we will need an official vote to ratify your elections. And so I seek a motion to ratify this slate.
So moved. It's Commissioner Adair.
Thank you, Commissioner. And a second.
It's Gary Allen, I'll second.
Thank you, Dr. Allen. Any objections? Great, motion passes. Yay, congratulations, Linda and Tammy. We look forward to another year with your leadership.
Thank you.
Thank you for the trust.
Yes, I was just going to say the same thing. So really excited to continue on that journey. And thank you, Linda, for being on that journey too. Excellent. So next we will, and thank you, Carmen, for that process and for everyone who weighed in as well. So next we'll go to redetermination update. Trisha.
Yes, hello, everyone. I just have a brief update for today. Before I jump in, I just want to do just what is redetermination again. So it's the process that the state uses to ensure that the Medicaid enrollees continue to be eligible for Medicaid coverage. Historically, this is done every 12 months of membership with the member. And again, this was put on hold in March of 2020 due to the federal public health emergency. So the update I have to provide today is that the public health emergency, or the PHE, was extended until January 11th of 2023. So the federal government said that they would give 60 days notice to the states before the public health emergency ends. So in absence of receiving, excuse me, I'm gonna grab a Kleenex, of receiving such notice, we're assuming that the public health emergency will be extended past January 11th to early April 2023 before it starts. What that means is after April, the months of April, May, and June will be used to notify members if the public health emergency does end in April. And then, so the month of July 2023, so halfway through next year before the soonest members will be redetermined or re-enrolled in Medicaid. And just as a reminder, the process includes front-loading members. We expect to remain members on Medicaid, so we won't really see any meaningful impact until October of 2023. And again, all of this is based on the assumption that the public health emergency will be extended until April. So last we spoke and I provided an update, we had anticipated it ended in January. So impacts on membership will be significantly less for 2023 than we previously reported. This change has had an impact on our budget process, and I know Justin will be bringing the draft CCO budget to the Finance Committee on the 19th of December, and then we'll be back in front of the board in January because this has had a significant impact in our assumptions for the 2023 budget. That's all I have, Tammy.
Excellent. Thank you, Trisha. Any questions for Trisha? Okay. Wonderful. Thank you for that update. So next we'll go ahead and turn it to Justin to talk about the follow-up on finance.
Sure. So the question that I received from Carmen via you all was, what was driving the very positive variance in the operating income? And the most recent versions of CCO financials that you all have seen were September, and through September, or maybe not September, maybe it was August, I think, where the question came from, but I'm going to use numbers based off of September. So through September, the operating variance year to date was about 21 million positive. And so there are three main drivers of that variance. And by main, I mean millions of dollars instead of a couple $100,000 here and there. Yes, I'm using those relative because maybe to some those are large, but just looking at the overall variances, one of the biggest is the prior year adjustments. And so in the CCO financials, we have tried to kind of just put some added visibility to what those prior year adjustments are. So to take a second, prior year adjustment in this instance is something that relates to a prior year. So in the case of 2022, an item that relates to 2021 or before. But for financial statement purposes, that year is closed. And so the activity is being recorded in 2022. So the biggest example, the biggest two pieces of that are incurred but not reported claims, so which is an estimate, and then the withholds and incentives related to the provider risk arrangements. And so on page 4 of the CCO financials, you'll see kind of like a breakdown of what those items are adding up to that amount. And so for 2022, those prior year adjustments total 13.6 million. So from that sense, that's one of the biggest pieces of the positive variance. And you can see the withholds and incentives being about 8.5 million, and then the IBNR related piece about 3.2 million. So that's prior year adjustments. Then the other two pieces relate to claims. So one of the things, the next biggest is the pharmacy claims. So that's sitting at about 5.6 million positive variance. And what we've seen in our pharmacy trends have been a lower cost per prescription, and then also lower utilization per member. So the members who are using prescriptions, their drugs are actually costing a little bit less than historical, and they're also, because our membership has grown so much, to some degree, the utilization is a little bit lower overall. So that's driving that positive variance there. And then the last biggest positive variance, obviously netted with some of the other hundreds of thousands of dollars negative, but are the claims. So if we look at the provider and hospital claims together, we're looking at about $3 million positive variance. And that predominantly relates to actual trends. Sorry, I phoned an actuarial friend to get a little bit more detail on this one. So what we're seeing is kind of an actual realized trends coming in lower than what we budgeted for. And that's predominantly related to the very thing Trisha just mentioned, the suspension of redetermination. So typically, when we think about membership and who would redetermine, it's those whose social determinants of health effectively have changed in some level because their income has increased. Thus, their claims and acuity is actually improving. And so the people who would otherwise redetermine have stayed on the plan, effectively reducing the actual trend that we're seeing in medical costs. So those are the three biggest drivers driving the positive variances. Is that helpful? Any questions?
Justin, go ahead.
Do you have a membership trend? Like, do you know how many member lives that was across, and did that stay about the same year to year?
For the medical?
Yeah, because you're carrying prior year over. So from one prior year to the other, I don't think there was a big change in membership. I'm just asking.
Not from year to year, but from our budget standpoint, the basis that they were using is a little bit different. And so it was just really difficult for them to determine kind of what population to expect when projecting out their claims and the trend utilization along with that budget. Gotcha. So it's basically just comes down to the best knowledge they had at the time to apply into the budget, and then it not actualizing the same way, but with some added detail, obviously, with redetermination.
So obviously, there's a data set below that data set that you put together, but as it stands, is it fair to say the provider groups are doing a much better job of controlling the total cost of care? Utilization is down in the inpatient setting. Utilization, in terms of spend, I don't know if headcount is the same thing, but spend wise, year to year, or are you just saying that that's carry through?
I am not sure I have an answer for you.
I think Justin S.A., because now it's not just Justin S. I think Justin S.I. is getting at, it's a combo, Justin, because there's the withholds from 2021 that are millions that are coming into that 2022 bucket. Then there's a 2022 performance with the pharmacy claims and the inpatient area that's millions as well. So I think it's a combo actually of performance, population change, and prior year favorability.
That's what I was getting at. All three would, to see that large of a variance, all three would mean that the medical group, that the providers who have the withhold piece must be managing the care significantly better. And with that big of a variance, there's probably some year to year, member per month changes. But
well, actually, so Justin, I'm glad you brought that up, because maybe Justin S.A. can talk about those withholds, because some of it, I think, is the performance gap in some of the incentives that did not get paid out to providers. Is that right, Justin S.A.?
Yeah, so I mean, if we look back at that table, the withholds effectively that weren't paid out, because at 12/31, I think we estimate 100% performance on both the withholds and quality surplus incentives. And so to the extent the 100% isn't met, that adjustment falls into the next year. And that's what we're seeing in that table. So 6 million of withholds was unpaid, and then 2.3 million of incentives was unpaid. Those amounts effectively flow into the JMA surplus calculation as unpaid, and then kind of get paid out via that avenue.
One way or the other, though, Justin, you have to earn those in one year or the other. If it carries forward,
Yes.
you still had to earn it as if the total spend had been met. If we had spent everything that was in there on care, there would have been nothing in the withhold category.
Except just in the hospital withhold isn't related to performance. So that hospital withhold, the half of that was, or the amount of that was not achieved from a quality matrix perspective, flowed into the 2022 year.
Gotcha.
So the surplus is true. Half of the surplus is quality related. So the lack of performance on that quality piece comes into this year. So it's kind of a positive and a opportunity, right?
Yeah. No, that makes sense. So, but in general, one way or the other, in general, to produce that large of a variance, the experiment on trying to control the total cost of care is working. I mean, especially in the medical spend area for medication, I think that money is not a realized carryover. That's actually better management for formulary.
It's better management to what was budgeted.
Yeah, gotcha. Okay. Well, that's a lot of good news then.
Tammy, can I ask a question? This is Mike Shercliffe.
Yes, Mike, go right ahead. And then Linda, I believe, has her hand up.
Okay. Me or Linda?
You go right ahead, and then Linda. Linda's on deck.
Under the claims, the medical provider fee for service is run with IBNR is 100 million and capitation is 24 million. Am I asking the wrong question? Is that going to be impacted by the value-based system and the risk-based stuff that's going forward that has to be implemented by 24? Will that be impacted? And is that a question to ask about that, Justin?
So that is a good question. I'm not 100% in the know on all of the expected contract changes with our provider network team, but as those materialize, I can definitely give a better update.
Is that actually a hole in the bucket in a way because it's fee for service and not risk based, or is the fee for service risk based also?
So to the degree we bucket things, we just kind of say there's fee for service and capitation. Anything that's not capitation, we're saying is fee for service. It's not necessarily bucketed as value based, even though there's a risk arrangement associated with it. So I think maybe that table is not as clear as it could be from the standpoint of identifying what's value based, what's true fee for service, and what's capitated to some degree.
Thank you.
Sure.
Justin, not Justin Civil, the other Justin Samudio.
Yes.
I want to go back to a statement I think I heard you say, and I want to make sure that I understood it correctly, and it was around redetermination.
Sure.
I think I heard you say that the longer a person is on the plan, their costs of treatment are reduced. Is that a correct understanding of what you said?
So I think I would maybe clarify that by saying the people who have rolled on to Medicaid during the COVID times, maybe due to a loss of employment, and have since regained that employment, but also have not redetermined and off of Medicaid, they typically tend to have a lower cost of care acuity. So they're typically a lower claims cost than those core Medicaid members who circumstances wouldn't have changed with or without COVID to some degree. So that core 60 to 70,000 members that we've typically seen.
So can I interpret that is continuous membership, not disjointed where people come off and on, but continuous membership translates into lower costs, or is that an inaccurate assumption?
That is inaccurate to some degree. I would say the lower cost strictly relates to this redetermination redetermination suspension that we're seeing. I think as soon as we see those Medicaid members, those members who redetermine roll off of the plan, we'll kind of see that gap between revenue and claims decrease. And then that's what we'll see in the budget as well. As we see those healthier or lower cost members redetermine, the margins start to shrink a little bit.
Okay. Thank you.
Sure.
So Justin, just real quick on that, wouldn't that would kind of stand to be a normal assumption though? Like if you're rolling off and you're picking up health insurance somewhere else, you would be using claims against the other system less too.
Most likely, yes. If there
It's not just a health status issue, it's a coverage issue if you're
Right.
against.
Right, yeah, but specific to this Medicaid environment, yeah.
And then the same thing back to Mike's question. The contract as built is one pool of money. So there really isn't a differentiate. I mean, there's a fee for service spend, but if you spend everything on fee for service, there's just nothing in the shared savings bucket. So essentially everything in fee for service truly is still risk-based.
Right.
Is where you're taking it from.
Yes, effectively. It's just what it's labeled as fee for service currently. So it's not traditional fee for service because I think we have risk-based contracts with most of all the providers in the region.
Absolutely. So irrespective one way or the other, the Medicaid contract is a risk-based contract. And the only option to insure more people is to lower the total cost of care.
Right.
Or shift where the money comes from or goes to.
Yeah, if there's more money, obviously. If the pool's bigger, totally.
Yeah.
Yes.
Great discussion. Any other questions? Samudio, great job. Civil, thank you for teeing us off with some good questions there. Really appreciate both of you. That was a great conversation. The clarification was really helpful for me too. So caught that in the chat, Linda. Thank you for bringing that forward.
Tammy?
Yes,
I know you want to move us on, but one thing that might be helpful for us to look at is where the CCO contract falls on the land framework.
Okay.
As far as value-based, that's kind of the national, the state of Oregon is using that to determine how far you are on the path to value with your contract. And then the other curiosity is people as payers and providers move towards that path of value and cost of care is impacted. What is the benefit of reducing the cost of care? How does that benefit us? Where do those dollars go? So I think that might be an interesting kind of discussion on the value construct and where we are and where we're going, if that would be agreeable to the group.
Seeing some heads nod. I'm wondering if Carmen, Trisha, could we maybe chat offline about pulling something together?
And Tammy, if I could expand that thinking
Yep.
a little bit, I think it might be helpful just to go back to mission and say, if part of our mission is to lower the cost of care, what does that mean and how do we measure it?
Love it. Trisha, go ahead. So you have a meeting set up with Peter McGarry, is that?
Yeah, Carmen and I are just meeting to complete the speakers list for the 2023 Board of Directors meeting. So we're hoping to get Peter McGarry in, I think, in Q1 next year, as soon as the community contracts wrap up here. So yeah, I think he would be a great person to come and ask. Then you can ask questions about where we are and how value-based payments work throughout Central Oregon.
Okay, wonderful. So Linda, sounds like we might want to follow that as well and make sure that we can bring that back to the board in an agenda, maybe February or March. Wonderful. Okay, so on to, if we're done with that, I don't see any hands raised, so I'll go ahead and move on to the next agenda item, and I'm going to turn it over to Carmen to talk about the COHC budget.
Great. Well, excuse my voice, but in your packet, you'll see the COHC projected budget for 2023. And this was approved by finance already, but wanted to just kind of bring to your attention some of the revenue assumptions that we're making, which includes the suspension of redetermination on that piece. And on the expense assumptions, there's really nothing that has changed much other than some savings on our operating budget, which our operating director here at COHC has found some savings, so we're able to realize some of that. I did allocate $1 million, as we previously discussed, on cross-sectoral projects or program initiatives from the last board meeting, and a $4 million allocation for community impact funds. We are now moving into year 4 of our 5-year RIP cycle. We've spent already 7 million of the 12, and we expect to spend another 4 next year, if not all of it. However, to be conservative, we're seeing 4 million go out the door next year. So that is pretty much it. A little bit more funding on our regional health assessment project, which is kicking off. We'll need your help on that. Surveys are underway, and we are going to be reaching out, doing focus groups so that we get the most out of that survey work across the region. This is actually the first year we are doing this survey work across the region. And so we're excited about what that will inform us. So other than that, there's not really much change, and just wanted to bring that to light. So Tammy and Linda, I don't know if you had any other questions around that or the board.
I'll go ahead and open it up to the board. And thank you to Finance for reviewing the budget as well. Welcome, Lori. I see that you joined us. Board members, any questions about the budget? Okay, so if we don't have any additional questions, then I will welcome a motion for approval. But not
Scary
everyone.
Allen, I'll move
Oh.
to approve the budget 2023.
Thank you, Gary.
This is Paul, I'll second.
Thank you, Paul. Any further discussion? Okay, anyone opposed? All right, motion carries. Thank you, Carmen. That's great. This might be one of our shortest board meetings because next, I believe that we had asked for a bit of time for Justin Civil on the update for Summit, but I believe we're going to punt that to maybe next month. Does that work best for you, Justin?
Yeah, thanks. I think, we're in the kind of closing stages of putting together what would be the country's largest value-based care company. And until that final item is struck and the final deal is done, I want to make sure I hold off, and then I can come back. And I think the company has some really amazing ideas for the Pacific Northwest and for our region in particular. And the capital and ability to invest will be, unlike we've ever had. So I think it'd be better if I can come back with like more specifics instead of, if anyone asks me anything, I'm at the part where I still have to say I can't say anything. So next month would be great if you don't mind.
No, that works really well. And we're grateful that you were there in a space to be able to advocate for the needs on the region side, but also be able to carry that forward back to this table to share in what it is that we can be doing to help support that effort, but also how that might impact our region. So I want to give you the appropriate time when it's the right time. And so just communicate with us when that makes sense.
You bet. Should be next month for sure. Thank you very much.
Cool. It's an exciting time, Justin. So
no doubt. Thank you.
Okay. All right. So that moves us into announcements. And Brad, did you want to talk about Measure 111 real quick? And I saw your request. I think that makes great sense. So.
Sure. Thanks, Tammy. I just wanted to acknowledge it, that Measure 111 passed, adding healthcare as a right to the Oregon State Constitution. Barely, but it passed. And I'm just curious if we have time today, but if not, punt it down, but to just talk about like, what does that mean for everybody who's a part of this board, your organizations and so forth.
Anyone want to share impact or insights or anything that you'd like to carry forward? It might be good for us to add this as an agenda item in the future, Brad, too, where we can do a bit more. The rollout, of course, will be an important piece of how all of that works.
Does anyone know what the next steps are on this? I mean, it was a challenging issue because it was not clear what the wording meant about commensurate with the funding of education and other things. If it's a state law, you have the law passed and then it goes to a committee to work out the implementation rules. Is it the same way on a constitutional amendment?
We have any legal minds on the board or representing? I kind of got the impression from the reading that I did that there was a lot of uncertainty as to what it meant. And so, I think to have some expert opinions maybe at a future board meeting would be helpful as to what the implications are going to be.
And I have more just opinion and guessing, I guess, would be what I would bring forward. So I am hesitant to share what I don't know. So I think it might make sense for us to see if there's someone who can come and speak a bit more clearly on what it is that this might mean. And I think there's a lot yet to be determined. It's a significant step for Oregon. And as you mentioned, Brad, it was not overwhelming in terms of the ballot, in terms of the measure, how it prevailed. So I think it'll be an interesting time to see how that rolls out. So Carmen, could we bookmark that as well, please?
Absolutely. I also have a legislative update in January for the board. So I know the session is coming up and I have someone doing a summary for all of that. So I think that will be useful in those conversations as well.
Thank you. Okay, other announcements?
My announcement is more what's happening next month for the board. It's time for us to do our board combined meeting with CAC. And so I believe the first part of the board meeting will probably be our usual business as such. And then the second half would be our combined board and CAC meeting. It will be live. It will be in at LCA. So we'll give you further details. Any questions, any thoughts, any other ideas on board and CAC fun things? I know we're focusing on relationship building, understanding what the relationship is between CAC and board. And I think there's just opportunity there to continue to build on that. But that's all I had.
For Linda, Brad, and Elizabeth, it might be good to know if there are any legislative ideas or things that are coming forward that you want us to add to the list for the January update as well. So if there are things that CAC might be tracking that maybe our list doesn't include, could be more broad and just maybe it's housing, who knows what it might be, but just would love to kick that our direction so we can add that to our legislative update for that joint meeting.
Well, I'm hoping it's already part of it, but the full expansion of Healthier Oregon is high on my list to cover all Oregonians with Oregon Health Plan benefits, all eligible Oregonians.
Excellent, thank you. And do you have a CAC meeting between now and January, or have you? I'm out of the rotation of when.
Yeah, next week.
Oh, excellent. Okay.
Well, Brad talked about call line or something so that people can ask questions on OHB and CAC. And we talked about that at our leadership meeting, but I saw it as a full-time position to answer phone calls on complaints. I don't know.
Thanks, Elizabeth. I just brought up essentially what the board, as we've been having this conversation for the past year with board and community advisory council interaction, the board said pretty clearly that what the board looks for from the community advisory council is consumer input, consumer voice. And I just feel like the consumer voice on the CAC is inadequate. I mean, I'd like to explore new ways to bring in more consumer voice. And a hotline is just one idea, just a phone line that, OHP members could call, and it's not a not a grievance line, not to take place of grievance and appeals by any means, but a direct line to a community advisory council that represents consumers. So it's a different thing than, you know, Pacific Sources grievance and appeals. It's be very different. However, we might get complaints. Who knows? We don't know. And we don't have any idea how many calls that would generate. You know, depends on how we. Again, this is just an idea, so I don't want to get too far into it. We haven't discussed this with the CAC. It's just an idea of mine, and there may be other ways. But I think, speaking generally, I think we need to put some energy into how can we increase consumer voice in this whole process.
So Carmen, that might be a good conversation for us with our joint meeting with the CAC. Is there a role for us to be advocating or leaning in or supporting in some direction that we're currently not as a board? And then if there's, Brad, I would encourage you, if there's something that you want to pilot, that, you know, let's give it a whirl. So chat with the CAC and see if there's something there that we might be able to support from the board with those efforts of engagement.
And
Right.
Tammy, sitting on CAC, it occurs to me that over, I'd say for at least the last year and a half, CAC has been unclear about what it is that council wants from CAC. So there's the provider level, being able to get consumer input at the provider level. That's really helpful. It's really specific. And the example of working with the dental providers is one example of how we've done that. The board also functions beyond just providers. Is there information, or can we give some guidance to CAC about what would be helpful for us at a policy level, given their unique experience and perspective?
Agreed. So that with that role clarity piece and clarity of what it is that how that interworking between the two, Carmen, something that we might want to flesh out a tad.
Sure. And what I know is that CAC and the provider engagement panel, so CAC Community Advisory Council, does have a charter, is my understanding. And so maybe that just needs to be refreshed back with the group and take a look at, as well as the Operations Council, which is going to be sort of revamped within the next year here. So stay tuned.
Probably a good level set for all of us, Carmen.
Sure. I can present the organizational structure and the council charters, and I can have staff help me out in putting that together, and we can do a presentation. And maybe that's part of the board and CAC discussion next month, is really understanding what that looks like. So
I see some heads nodding. That sounds great.
okay, great.
Okay, other announcements or comments? Okay, well, this might be our shortest board meeting ever. So with that, unless anyone has anything that they'd like to bring forward or something that you want on agendas for next year, or just I'll sort of open it since we have the time. Is there anything here that folks want to bring forward? Okay, well then, yes, thank you, Patty, and congratulations on your reelection as well. We missed you last month, didn't have a chance to say hello. Just want to say to everyone, enjoy the holidays and be safe out there. Thank you so much for your commitment to our region and for the time and commitment to this particular work, and more to come. So we'll see you all after the beginning of the year. So, bye.